So kia ora. It is with great pleasure that I get the opportunity to introduce to you the panel for today's discussion. But firstly, I can't start without ko ai au. Who am I? My name is Leilani Maraku. I am really privileged and proud to be the mental health rep for the NGO Council and also the manakura for Mano Te Tangata Trust, which is a kaupapa Māori peer support addiction service, mental health and addiction in Mid-Central. And I just want to thank everyone for being here today, and also a big shout out and acknowledge to Mid-Central whanau that I can see out there and everyone else that's made the journey today. It is an honour for me to be able to introduce this amazing panel we have here. And first up, I would like to introduce Dr. Maria Baker, Pouwhakahaere Mātua CEO of Te Rau Ora, formerly known as Te Rau Matatini. Maria is a registered nurse and brings 20-year history in Māori health with a focus in mental health for adults, added to by her doctorate research and Māori experience of mental illness and mental health services. Maria has worked for iwi NGO providers in rural communities, in addition to DHB roles that have relied on NGO workforce and provider delivery. In the last decade, Maria's focus has been in workforce development, system improvement and innovation, and fostering evidence of what works for Māori. We next also have up Dr. Garth Bennie. Garth joined NZDSN, which I looked up, and that was Disability Support Network, in January 2015. And since then, he has led NZDSN into a new era of closer ties with government and across providers. Garth has a wealth of experience in around disability sector with 15 years at the Ministry of Education as a district manager for special education. His career began in IHC in both vocational and residential settings, where he trained as a social worker, and since then has had a variety of roles, coordinating, managing, researching and developing disability services and policy. He gained his PhD on disability studies, particularly focusing on supported employment. We also have to my left is Dr. Barbara Disley, Chief Executive of Emerge Aotearoa, a large national mental health and drug alcohol NGO. Barbara has worked in a number of non-government organisations, chief executive roles, including the Mental Health Foundation, Richmond Fellowship, and now Emerge Aotearoa. Barbara was in the inaugural chair of the Mental Health Commission, leading the development of the first mental health blueprint. She was Deputy Secretary, Ministry of Education, where she had responsibilities for special education. She was a member of the Confidential Listening and Assistance Service, and the forum set up for people who had been abused while in state care in New Zealand, and chaired the review of the sensitive claims area of ACC, which supports victims of abuse. Over the past year, Barbara was a member of the inquiry panel set up by the government to review mental health and addictions, and in 2011, Barbara was made an Officer of New Zealand Order of Merit for services to mental health. So wow, what awesome leaders within our across New Zealand we have here. And for our panel and how we're going to start is around commissioning for now. The challenges of the current health and disability system requires innovative and energetic responses. The NGO sector is an expert at delivering high quality services in a wide range of contexts. Diversity is one of our key strengths. Living within our means is another one that we do really, really well. We want the opportunity to hear from the perspectives of these three different NGO sector leaders on their views about what has worked well, what hasn't, and what would be better with regarding to planning and funding of services. First up, we have Maria.
Kia mai tātou. Ngā mihi mahana kia koutou a katoa. Cool, alrighty. Straight into it, and what a wonderful presentation. Really hard to listen to yourself being described. Anyway, kora mai tātou. Māori leadership. Māori leadership's played a key role in NGO and community responses in this country for centuries. When we look at it, there are specific key attributes, aren't they, in Māori NGOs? Whakapapa, so genealogical relationship and connection to the people. Māori models of health, this one very familiar to many of us who started work anytime after the 80s. Māori cultural processes used as a basis for developing and delivering health and social services that's support self-sufficiency and Māori control. Whanaungatanga, Māori are the best relationship specialists this side of the world and will represent the needs of Māori. They will identify access issues as the key factor and strive towards the range of strategies in order to be able to address those. The focus also within NGO Māori is on us, on the employment as Māori as best as possible, so that their staff are more likely to be able to access the Māori communities and the knowledge base and the values actively included in those communities that they're delivering to as well. We know that the Māori NGOs are positioned well, but unfortunately we are located in an existing system expected to fix various problems. Though Māori NGO are holistic, and we do lots, we go over and beyond, but the systems constrain them and don't allow most of the time for them to fully realise their ambitions. When people say Māori providers lack capacity, it is most likely those people saying those things have a minimal understanding of the depth of NGO Māori, nor the variety of expertise that are within those places. They might also comment that some of the infrastructure and the geographic limitations of NGO Māori may challenge us, but in fact it makes us richer when we are in our locales delivering to our own people. When we think about NGO Māori, we also need to consider the recognisation of the weight of responsibility of the concepts that are of value to us: spiritual, traditional, cultural, contemporary, all the significant things that are important for a people that are the first people of this land. We also understand and promote that it is not enough to incorporate Māori names or ideas on an approach that does not generate a kaupapa that is true to being Māori. For Māori, it is about a wider aspect. It is about kaupapa. It is not about the people that are in those organisations alone. It is about the desire to make a difference to our people now and to the generations going forward. We've been fortunate, haven't we, in our time, to see that in the last period of a number of years, we have consistently challenged the system for something different. And in doing so, we ask the government to turn their gaze away from a deficit analysis onto one that is more positive, that is aspiration-oriented, and is whānau-centred. For those of us working in NGO environments and in communities, we are aware of the whānau ora approach and the idea to centre all it is that we are aiming to do as an NGO sector on the family, on the whānau within their communities. These are the 7 whānau ora outcomes. Some of the challenges for us have certainly been how funders have treated NGO Māori. In some sectors, funders are now starting to seem to be pulling back on the roles and starting to make decisions for some of these providers. Again, signalling that some of the gains that may have happened decades ago in terms of the 1990s when Māori health service reform occurred, that perhaps that the investment that was promised earlier on in terms of capacity and capability for NGO Māori have not really been sustained. We know that the system in which we are working in is driven by a westernised worldview, where NGO are not seen as the sum total, are seen as the sum total of their contracts and not as a critical partner or contributor to the overall system towards well-being. Certainly, no provider anywhere should be getting any funding without demonstrating their ability to meet the needs, but Māori need to have the option and access to Māori providers and Māori delivery within their communities. Maintaining the status quo for NGO Māori will never get us there to where we want to aspire to, and particularly given the timing is right, with the wellbeing budget and many people saying clearly that we need to be doing more. But to get a better relationship with NGO Māori and the funders, the systems need to shift now. There are a range of ideas about how to do that, and one of those ways is to hand over the power and the resources to establish a Māori Commission. The suggestion is not new. In fact, if you look further away back This corridor came up in the 1990s, and again we've heard about the tribunal or the Y claim of the 2575, where it has also raised its potential again. So it is not new. So what might that mean? A Māori Commission could be an agency who will have the responsibility to work beside Māori, to purchase the services, to enable the resources for Māori. This is just not community, this also includes hospital level services. The biggest challenge perhaps for a Māori Commission will be not in terms of the work on the day-to-day basis, but in the establishment of what an evolved Crown-Māori relationship might look like. The signal is already here, whānau. The government has already sent us two clear messages. One is that there is currently a Crown-Māori relationship portfolio separate from the treaty negotiations. They are ready for evolution. The new portfolio would look to distinguish the redress of wrongdoings from the opportunity to improve how the business of government is done to better reflect the articles of the Treaty of Waitangi. Doing better will mean having broader conversations with Māori in their communities and exploring how the relationships will work at the NGO level and in community to advance wellbeing outcomes. So, here's a kōrero for you. To modernise any of the practices around procurement, we would like these things: to be simple, to be less administratively burdensome, to be holistic, to support the wellbeing policies now and ahead, to support innovation, and to be determined by Māori. Kia ora mai tātou.
The disability context is rapidly changing. The Enabling Good Lives principles, which emphasise choice, control and self-determination by disabled people in whānau, and we have a transforming disability system which emphasises flexibility, independent facilitation through roles like the connector, and access to personal budgets with a continuum of management options. However, current commissioning is characterised by things that are often entirely at odds with that course that's been determined. So we end up with a predetermined menu of options with very prescribed service specifications that usually just default to congregate programs. We have pricing that is entirely out of step with actual costs and no acknowledgement of the need for margins to invest in innovation. There is a very business-like model around procurement and contracting which ends when it comes to pricing, and then the business model suddenly evaporates. We have rationed access to resources and services depending on how annual budget appropriations are tracking, making it very difficult to invest in longer-term outcomes for individuals in whānau. And we often fail to make a distinction between actual need and current affordability. So the current system has been very effective over the many, many years in suppressing expectation and suppressing need. Commissioning is also spread across the Ministry of Health, the Ministry of Social Development, and some DHBs with very little or no integration. So in developing some more promising approaches to commissioning, we need to take account of the fact that the sector is going to be organised around the assumption that increasing numbers of people will have access to personal budgets and can therefore choose to commission their own services and supports, either bespoke arrangements, direct access to mainstream services, or from a disability provider marketplace. And it's worth pointing out that we already have probably something approaching 5,000 people in New Zealand who already have access to personal budgets. There is already quite a lot of experience and knowledge and experience in that. So what are some of the promising approaches? Individualised funding has been with us for much more than a decade. But where resourcing of personal budgets is limited to selected budget lines. We have EGL demonstrations in Waikato and Christchurch in the mid-central prototype, which enables access to personal budgets that involve a much broader range of budget lines. We have things like I Choose, a flexible approach to respite, where families can choose to design their own bespoke respite arrangements from within a defined budget. However, that's yet to be implemented. Flexible disability support contracts, or FDS, enables a provider to engage with people who have personal budgets and a personal plan, and negotiate a range of roles, whether it's direct service provision, hosting arrangements, brokering, other services and supports, facilitation, coordination. But currently that's only available in Christchurch and Mid-Central. So some suggested next steps to expand commissioning that does show some promise. Implement I Choose. Let's get on with it. Roll out FDS nationally to encourage engagement with and implementation of EGL principles. Create an environment that encourages innovation and creativity. Even within the limited constraints of budgets at the moment, there is plenty of room for that innovation to fly. Expand the prototype to Canterbury and the Waikato. Let's get moving. We are really concerned about a loss of momentum. Design a sustainable funding system and an operating model that supports EGL, system transformation, and enables those longer-term investment decisions to be made in people's lives, and deals to a system in New Zealand that discriminates on the basis of cause of disability. We have got to crack that one. Develop a national framework and an integrated cross-government strategy for commissioning that is aligned with EGL principles, and that can inform and guide procurement. But there are some constraints, not surprisingly, on some of those developments. One, of course, is that we have a funding system framed by annualised appropriations that is at odds with a long-term investment approach that emphasises flexibility and beginning early in the life of the person, early in the life of the issue or the barrier. We need to understand that in a transformed system, the primary contractual relationship sits between the funder and the disabled person in whānau, not the provider. The personal plan in that environment is the service specification. So flexible disability support contracts should be very simple. I'll leave that at this point. The absence, of course, of a consistent approach to commissioning and procurement that's aligned to the EGL principles. Some other constraints for the near and medium term future is that commissioning will need to maintain the legacy of current models, as well as enable investment in improved early intervention, better support for families, and more individualised and bespoke approaches. Supporting the past and the future at the same time does have an added cost. We need to accept that. Increasing flexibility through some of the promising approaches that I've mentioned is likely to have an impact on demand and cost. And we certainly see that in the prototype, where I think the latest statistics is that 30% of the people accessing the prototype in Mid-Central are previously unknown to that system. So we have been very, very good at suppressing and hiding need. Commissioning also needs to be aligned with EGL principles and take account of some other very real challenges if we're going to move forward and realise the principles of enabling good lives. One of those is the scarcity and affordability of accessible housing. Right when we needed a housing market that was accessible, it's the least accessible it's been in most of our memories. Secondly, the appalling level of employment participation by disabled people. Absolutely appalling. We have got to have commissioning that aligns and takes account of addressing those issues. And lastly, the lack of access to independent advocacy and supported decision making, particularly for those whose voices are simply not being heard. Just a few things to do. Thanks very much.
Now we have Barbara.
E nā reo, e nā mana, e nā iwi, nā mihi nui, nā mihi araho, tēnā koutou, tēnā koutou, tēnā koutou katoa. Well, I thought I'd start by summing up, because I was told we only had a little bit of time, because we're over time. So for me, commissioning must give power. There's three things I've pulled out. One, that commissioning must give power to the voices of the people who will access services. And having been on the inquiry panel, what I saw is if you get out and talk and get into communities. They know what the solutions are. They'll tell you what the solutions are. It would be much easier now to go back to those communities and start where they are and work forward, because they have worked through what the answers are. They live it. The second thing is really follows from that and is tēnā rangatiratanga, and it should be a core principle. People who are most likely to access the services should have stewardship and self-determination built into whatever it is they end up getting. And that should be for them and for the people that they care about. And the other lens that has to sit across anything is equity. And I put a challenge out to all of us to start to look at our own data and information through an equity lens, because sometimes you'll find it rather horrifying, even within your own service, to look at who gets what and what the outcomes for the various parts of your own system is. So it's not their problem, it is our problem to begin to do that. And so if you look at the health outcomes, as we well know, for Māori, for Pacific people, for people with disabilities, and for people with mental health challenges, they are much, much poorer, and they live many, many shortened lives. And it's often driven by gatekeeping and decisions that are made about what other people think other people need or are entitled to. And so they're the three things that I think we need to think about. For me, at the moment, we have very fractured commissioning. It was really interesting to see that different people fund prevention promotion initiatives, from those that fund primary health care, from those that fund secondary health care, and every DHB in our country, every 20 of them, does things differently. The Ministry of Health then zaps in and does some other things. The PHA does some other things in the promotion area. So no wonder we don't have a cohesive system that's easy, that flows around particular groups of people and supports them. It's also not a level playing field. Frankly, DHBs are providers and funders, and as much as they might want to, they actually end up feeding themselves first, particularly when they're starving, right? So I just think there's some of the things we're going to have to look at. So what might work better? Co-constructing with the people who need and will access the services has to be a core plank of any new system. Greater equity has to be a key driver. Independent commissioning must be there, and that could be regional or national, but it has to be quite clearly close to the people and built on what people say they need. I agree with Marie, there needs to be a separate Māori commissioning process, and Whanau has established that getting in early, wrapping around people, supporting people is likely to be a way forward. And that's not probably just for Māori, that whole principle. We need to shift the quantum of our whole system. We spend a whole lot too late. And we need to integrate and put the incentives in the right place to get people doing things better earlier for people and building in a wellness model. And I support the direction of the child wellbeing strategy that's come out of the Department of Prime Minister and Cabinet. So for me, stepping forward might mean stepping back. I usually don't step back, but I remember the days. I won't say the good old days, they weren't all good, but I do remember the days of the health funding authorities, the regional health funding authorities, and I just bring them up because I happen to remember that was the time of greatest growth in this country for NGOs. And why was that a period of greatest growth? Because there was an independent, regionally based funding mechanism that looked at where the population needs were and started, before they got demolished, started to shift the resource to match where those needs were. And so for me, that's when we went from being, as an NGO provider in the mental health sector, from being getting less than 3% of the budget to actually moving to the position where many of us were getting much, much more of that. So for me, looking back sometimes can give you a model for looking forward, and I think that's a really good thing. I think we have to look at hubs and we have to look at specific and individual populations and look at what people need and how they might get that. Valuing lived experience has to be a deep principle in everything we do, unless you've walked in people's shoes, unless that's been built in, and unless people have control, then we will not get what we want. We'll get more of the same, which is probably more of the highly medicalised end part of what happens, and it'll be impossible to move the gate down that way. So, and the other thing, in terms of commissioning's not all of it. We need to fund and build in mental health a diverse workforce and train for the right skills rather than ignore it and hope that this will happen. And I absolutely support the fact that we need and are looking now at a workforce that primarily will have a large peer and a workforce with people with lived experience that can get in early, support people in all the things they need before they end up, needing a secondary system. And that includes a strong Māori self-determining workforce that responds to the needs of Māori, and likewise Pacific for Pacific should be a choice.
Ngā mihi to the panel. Before we go out and maybe ask if there's any comments or questions from the floor, I'd like to ask the panel if you were to make a change to the commissioning approach and able to do it tomorrow, what would that be? Who would like to start? If we could change it tomorrow, what would that change to commissioning approaches be? And if you could make it in your region or your area, what would that look like and what would that be?
For me, it's evolving the power. The issue is that the decisions are still being determined by non-Māori. The power needs to be, Māori need to be in those positions, Māori need to be in those places. That's easy for me.
I guess two things. Expand access to personal budgets so that more and more people can commission their own access to supports. And roll out flexibility, disability supports across the country so that the two can work together.
For me, it would be pulling all the mental health money out off the DHBs. Oh, did I say don't?
And addiction.
Yep, mental health and addiction, pulling all that money back and then working with the communities and really, really shifting the locus of control and the direction of those services. Because frankly, going into a mental health unit, and I know they do great work, many of the people in those units, so I'm not saying that, but it is not the only option. We could do a whole lot of crisis intervention, acute services, respite options, peer-led services, a whole lot further down the track before people are left to deteriorate to the point that the only option available for them is a hospital-based inpatient unit. And most of them aren't therapeutic, unfortunately. They can't be because of the way they are provided.
Teresa Wall. Kia ora, Teresa.
Kia ora. So have we got a couple of questions from the floor? Yeah. Could we just get you to repeat that one?
How many commissioning agencies are too many?
Yes, now from just listening to you guys, we've had, I can't remember your name.
Garth,
Barbara.
Gentleman.
Maria, Garth.
Garth.
Yeah, so how many, potentially every single person who needed to have disability services would be a commissioner. So how many would that be?
Well,
how many population?
Several thousand, but
Yeah,
the idea is
right.
that you have an overarching framework
Right.
guiding
So
what they do.
Several thousand individual commissioners. Then, Maria, you've said you want a single Māori one.
Well, that's one way.
On top of 20 DHBs.
No.
The ministry.
No.
The ministry.
Those structures would be gone, Teresa.
ACC. I'm just saying. We've been proposing to have all these commissioning. So who would you get rid of? And how many would be too many?
They need to be devolved. So all those resources need to go into. I mean, can you imagine, Teresa, iwi, who are poised and ready to commission whatever it is that desires to meet the uri within their rohe or wherever their uri are. We already see the wonderful work of Ngāi Tahu and many others that are being in post-settlement that are investing in the grassroots across elements of the capitals and the korero around well-being. So those are commissioning possibilities. There's all sorts. In some of our areas. Well, why is the number a problem? Yeah.
Excuse me, can we just have the mic so we can just hear that? Sorry, just wait. Yeah. Okay.
And the proposal that we need to put another plethora of commissioning agencies or commissioners in to solve a set of problems. And I'm not sure that we've actually defined what the problem is that we're trying to solve, and then we haven't defined clearly what the problem is that we're trying to solve, but we've clearly decided that this is the solution.
Don't know if I agree on that, but kei te pai.
Okay, we've got another one just over here. Thank you.
Kia ora, Prudence Stone, Public Health Association. I'd just like to tautoko Garth's mention of advocacy. I know you were talking mainly about advocates on an individual basis, and so of course that's a tautoko to the Whanau commissioning model, because in my lifetime in public health I've seen the emergence of a new word, navigator, who in the vernacular of health has replaced the word advocate on that individual basis. But what I think is an elephant in this room is the lack of funding and the need in our sector for effective advocacy skills on that legislative and broad policy overarching level. The human rights framework, for instance, it needs to be a skill that all of us in the sector have. And I wonder where and how whether commissioning as opposed to contracting is any solution, or whether you've got any sort of thoughts on whether advocacy has more opportunity in a commissioning framework as opposed to what we've had before.
The prototype in Mid-Central is funding. It's calling it supported decision making, but essentially it's advocacy to support people's own decision making, based on the assumption that there are large numbers of people in the disability system who don't have a voice. They may not have family, they may not have others around them, and may have very acute difficulties communicating their needs. And the essential component that needs to be there is funded advocacy or supported decision making that enables someone to be alongside that person who is just there for that person and that person alone, so that voice is heard.
I just can add, Prudence, I think one of the challenges would be is to situate advocacy within a structure that procures money and determines resource. So we already have those sorts of structures. We've got to look at unpacking how resources and support can go to family or people who can then determine advocacy and the type of things that they need when they need it.
Okay, I've got another question.
I love the enthusiasm, Maria Mahinu kia koe. I challenge the practicality of that, working in a not-for-profit and have been in the sector for a long time, one cap after the other. advocacy on behalf of services or individuals is both funding threatening and career limiting.
Tēnā koe,
I'm
Paula.
still standing, as the song says.
As you are, and looking great.
It is. It's a dirty word for a long time, advocacy, and yet you have to advocate.
Oh, no
Because
question.
you've got to say, and I've said this many times this morning, we've got fantastic wellbeing budget. All this money is on the cliff. Awesome. We have got to stop people falling off, and that's about the environments that we're saturated with junk food, tobacco, gambling, alcohol, and all the rest of that stuff that someone's making money off, but it's not the people we're helping.
Aye.
And when you speak up to advocate for change there, then yes, you do hit the career limiting and funding threatening brick wall. But we still do it.
Tautoko. Kia ora.
Yeah. Okay, we'll just have one more and then we'll have to round this up. Thank you.
Kia ora koutou. Thank you, that's very interesting. There's a couple of mix of models, or suggested models, and one that's actually in place and sort of some suggestions that could be worked. So my question is, and sorry Garth, because yours seems to be the most worked up one, what is the, how do they understand the evaluation around the impact on equity from that change in that funding model? Because it's a big, bold change, so how do we know that the people that need the services the most are actually going to receive it in that model, when my naive understanding is those people who have good, strong languages, knowledge of the system, are able to speak loudly, will find it really, really useful and get a lot out of it, but some others may not. So how did you evaluate that? And I'd like to understand what the evaluation framework looks like. Related to the other two parts there is actually with your suggestions, how would you also address the understanding of equity and outcome?
Well, I think it's going to be very important. I talked about when people have personal budgets, to have access to a range of management options so that people can find their own sweet spot in terms of how much of involvement they want to have in that direct management. And that speaks to the need for a range of supports, including advocacy, that need to be around that. I think one of the challenges that we have, and we have to be very careful about, is that if we don't put the right safeguards in place, then what's being proposed will simply reflect and even exacerbate the inequities that already sit there. So safeguarding that is really, really important, and evaluations must speak to that.
Now, sorry, I've just been given the heads up. We've got enough time for 2 more questions. So,
Hi Garth, it's Jerry. You can't see me.
But I know you, Jerry.
Backing up what Garth is saying, there's a phase 3 evaluation up on the Enabling Good website, Good Lives website from Waikato, the demonstration, and there's been significant improvement in outcomes. So just Google Enabling Good Lives and you can find it.
got one more?
Just to really strengthen the mental health and addiction comments, I think possibly we in that sector feel the effects of the current commissioning problems the most. I mean, others may differ, but if we don't change how we commission and who does it, we will not achieve transformation that this budget and everything else is talking about, because we will have more of the same. And I agree very much with you, Barbara, that yes, HFAs weren't perfect, but they were a hell of a lot better than having 20 bloody DHBs doing it ineffectively. And yes, they do feed themselves first. And I don't know that there's any of them here, but I'm not scared of that. They know what I think about that. It's, if we're going to commission for outcomes, and there's a commissioning framework for outcomes. There's an outcomes, population outcomes framework that's disappeared into ether. But if we are really going to change things, We have to shift from FTEs, bed nights, widgets, into real outcomes, real difference made for real people. And we can't do that under the current system.
Thanks, Peter.
Come on.
That is us. Thank you.
Thank you. I'm Sonia Thursby. I'm a member of the NGO Council and also on the New Zealand Federation of Information Exec. So I've just sat here and gone, wow, what passion, talent and amazing people we have in our sector, and I get to sit on a council with these ladies and with Barbara. So that should give you some comfort in the expertise sitting around that table trying to make sure the NGO sector's voice is heard. And Garth doesn't sit around the table with us, but he's only around the corner in Wellington. So we certainly liaise with Garth on a regular basis. Most of us have just been to the NZDSN conference. So a huge thank you, Garth, for joining our panel. And we're grateful for your message.